evening, everyone. Obviously, it's a tribute to Carlos that so many people are here after a full day of meetings. I guess we are the true believers in trying to understand the implementation of PrEP. Slim Karim this afternoon sort of talked about where PrEP was, and tomorrow morning I have the privilege of talking to folks about where PrEP is going to be. So today let's talk a little bit about where PrEP is right now. So we have this very key, almost dose response that if people are adherent, you can see high levels of effectiveness of PrEP. Jim Rooney will be talking some about some of the projects that are now being supported with medication and other supports from Gilead. And at this point in time, we've moved from a finite number of people in clinical trials to this transitional period of demonstration projects. And I think one of the most important things you heard yesterday from Bob Grant was that when people know that they're not randomized to placebo-controlled settings, people, if they self-select, have high levels of willingness to adhere to PrEP. And data presented at the Retrovirus conference from the project led by Al Liu and Stephanie Cohn, which is involved participants in SD clinics in San Francisco, Miami, and at Whitman Walker Clinic in Washington, D.C., has indicated a high level of utilization, so that the levels in San Francisco, consistent with people taking at least 4 pills a week, was over 92%. And these are earlier data, and if anything, the levels of adherence have increased over time in these settings. So there clearly are a self-selected group of people who understand the risks and benefits, who are interested in using this strategy for chemoprophylaxis. There's been a lot of attention in the U.S. and I imagine globally, the term Truvada horrors and the perception that there's going to be pushback, but there's also a lot of very rich discussion in the blogosphere, and there's some great resources that have emerged, and it'll be very interesting and important to track to what extent they may be influencing people's decisions about PrEP. So Jim Pickett, the AIDS Foundation Chicago, has assured the videotaping of a diverse group of people who have decided to take PrEP, and then to talk about their experiences with PrEP. And these video testimonials, I think, are extremely powerful. At Fenway Health, which for those who are not familiar is a community health center, about half the patients are sexual and gender minority patients in Boston. Fenway was involved in the CDC safety study and the ICAAC efficacy trial. And at this point, we're trying to see how do we implement this within our local and larger community. So one of the things we've done, we've created a fixed part of our website where it's a /PrEP info. The Fenway Institute is our research, education, dissemination part of Fenway. And we created a bunch of monographs. We have some federal grants also to education around LGBT health, and so this dovetails very nicely in terms of disseminating best practices around HIV prevention for individuals who may be considering PrEP and also for clinicians. We've also, with support from Gilead, been able to undertake a number of web surveys over the past few years. So this was the most recent survey that we took at the very end of 2013. It was reported at the Retrovirus conference in Boston. So what you see in the map, the deeper colors are in terms of the percentage of the respondents. So we have a lot of respondents from Massachusetts, New York, and California. The individual numbers are people who actually said that they had taken PrEP. So in this sample of men who were recruited on Manhunt, a social networking site for men who have sex with men, the sample is almost 10,000 individuals. About 1.2% said that they had used PrEP. Levels of PrEP knowledge had increased compared to an earlier study we did about a year and a half before, but still more than half the individuals were not really familiar with PrEP. We also asked people about whether they'd used post-exposure prophylaxis, and the prevalence there was over 3%. We were able to do a multivariable analysis then and look at what were the characteristics associated with PrEP usage in the population. So individuals who were more educated, who were diagnosed previously with a sexually transmitted infection, who had used PEP, so they had some experience with antiretroviral prophylaxis, and I think a very important piece of the puzzle, that they were comfortable talking to their providers about having same-sex, so that clearly part of the intervention, we need to increase the appropriate uptake utilization of PrEP. They be important to educate providers and to educate consumers to identify providers with whom they are comfortable. So tomorrow I'm going to spend a good deal of time talking about where PrEP may be going. We heard data presented at this meeting from the HIRI-MSM study, which is episodic PrEP. Bob Grandin's leading a study in the HPTN, which is looking at less than daily dosing, trying to understand whether fixed intervals are associated with higher levels of adherence compared to more episodic dosing. And that study has recruited men who have sex with men in New York, maybe in Harlem, New York, in Bangkok, and women at risk for HIV in Cape Town. There are other drugs being looked at and other formulations, but let's concentrate on how are we able to enhance what we know about in terms of what's proven, which is daily chemoprophylaxis. Well, one set of issues that really need to be addressed are that some of the reasons why individuals may have difficulty negotiating safer sex may relate to lack of agency, may relate to affective issues, and these also may affect adherence. So addressing some of the concomitant mental health issues that people may be confronting may be an important part of the PrEP package. So with Steve Safran, a clinical psychologist, a colleague of mine at Fenway and Harvard, we received funding from the National Institute of Mental Health, and he had developed an intervention called Life Steps, which was a medication adherence intervention for people living with HIV, and we've tried to see how do you adapt that for people who are not HIV infected, trying to also be sensitive to the amount of time that physicians may be spending with patients. So this is a nurse-delivered intervention, involves cognitive behavioral principles for enhancing adherence, but also dealing with some of the behavioral triggers why people might not be adherent to medication. The good news so far, it's R34, so there's a small pilot. The intervention seems highly acceptable and there's high levels of adherence. But as many of you who do these kind of trials, our control group also has high levels of adherence as well. So we're in the final throes of analyzing the data and hope to present it at HIV R4P. But one of the principles here I think is really important. You may all be familiar, but it's important to know about a study by Lester et al., which involved people living with HIV, and this involved text message reinforcements in conducted in Western Kenya. And this was associated with a significant level of virologic suppression. So the question is whether we can use these kinds of electronic media to enhance PrEP uptake, utilization, reinforcement with individuals going forward. A very interesting other creative study is led by Landovitz, which involves giving stages of different kinds of counseling. So there's pill counts and recall, but they're also measuring drug levels in real time, and if the drug levels fall below a certain threshold, there's additional counseling with enhanced next step counseling developed by Reve and Nico. They actually have not had to kick in this more intensive phase because individuals tend to be quite adherent in the study. Al Luz in the audience is also going to be able to talk about some of the different ways in which the San Francisco public health intervention is trying to track and enhance adherence.
We also have to think about MSM are not a homogeneous population. So in the last few years, the HIV Prevention Trials Network had a study, HPTN-061, the Brother study, which enrolled more than 1,500 black male subject men in 6 cities across the United States. The incidence overall was extremely high, and particularly concerning was the incidence among men less than 30 years of age, almost 6% per year. These are individuals who were into the study, monitored, followed up, and offered peer health system navigation, and still this high level of HIV incidence. We found high rates of sexually transmitted infection, and the men we identified were in advanced stages of HIV infection. We identified many unmet social needs of high levels of incarceration in our society. So there's a study now, a PrEP demonstration project underway, HPTN-073, led by Donald Miller and Sheldon Niels, who's at this meeting, And this study is enrolling Black minocycline in Washington, D.C., North Carolina, and Los Angeles. It's more than 2/3 enrolled, and individuals do not have to initiate PrEP. Their willingness to participate in the study, so there's no increased incentive to initiate PrEP. But the majority of the individuals, approaching 80%, have initiated PrEP and appear to be adherent to study visits, drug level they will be pending. Sybil Hosick in Chicago has been a pioneer in thinking about how to roll out PrEP for younger menocycline. The initial study that she undertook, the Adolescent Health Network study 082, enrolled a cohort of primarily young men of color. And these individuals subsequently were able to enroll in the ICAAC open label, so you have the choice to use PrEP or not. The majority elected to take PrEP, and with increased counseling, drug detection levels increased over time. There is a further study now in the Adolescent Trials Network in 5 cities in the U.S. that has enrolled 200 young menocycline between the ages of 18 and 24, and there's an earlier age study of 15 to 17-year-olds that is still enrolling Parkinson's, trying to enroll a sample of 100 young menocycline. The study question here is it better to offer a concomitant behavioral intervention as a group intervention to build on peer support, or to do an individualized intervention? So it's using the CDC evidence-based interventions and comparing group versus individual intervention plus PrEP. Providers are another part of the equation. I'm working to work with young physicians very interested in doctor-patient communication. Krakower is very curious. They may want to go into further detail about the data that Gilead had collected that a lot of prescriptions for PrEP were written by individuals in southern U.S. and not by HIV specialists. And people were surprised to that places that had large populations of people living with HIV were also going to be offering PrEP. And there's coined a term called the Purview paradox. A paper was just published in Age and Behavior, and this involved a lot of qualitative interviews among healthcare providers in Boston and teaching hospitals as well as the community health centers. So the essential Purview paradox is that specialists essentially were saying, I take care of people living with HIV. I don't once in a while I'll counsel their partners, but I'm not going to have people who are not HIV infected come in and for me to provide chronic engagement with them. I'm an HIV specialist. And then generalists said, I do take time sometimes to talk to my patients about their sex lives, but these antiretroviral medications, they're very complicated. I'm not comfortable taking care of people with them. Doug's gone on to identify further perceived barriers that providers have. It's really a further agenda for research in the U.S. and around the world. And you can see a lack of patient requests were a barrier, concerns about insurance coverage. You may want to talk about in the U.S. which is more perceived than real. The clinician not perceiving that they're having to be trained, that's something we can certainly act on. This study was done completed about a year and a half ago, and there already was CDC guidance provided because they were not aware of this. And the providers here were interviewed online. These were people at least having one CME course in the preceding 3 or 4 years by our education and training centers. So this might be overrepresentation of people who might be expected to know something about HIV. Time constraints is certainly a generic concern by providers, but not being aware of PrEP and perceiving that they didn't have a lot of at-risk patients. These are concerns that we have to work with if we're going to be able to implement that to resolve a prescription. Don Smith at the CDC has brought about one way to deal with this logjam, which is to develop a heuristic. So this is a screening tool that if an individual scores 9 or 10, there might be consideration that they might be a candidate for PrEP. One might think about use of neuroelectronic technology to be able to interview people, get the data, and have a much quicker way to at least screen and pick who's the perfect person to have a PrEP discussion with. The other concern that has been raised is the cost-benefit of PrEP. These data presented by David Lynn at the Electronics Conference was published by Susan Brookline and colleagues from the ICAAC. He basically plotted the different studies and you think about the incidence and then the number needed to treat. Even though Capriso was under 40% of the intended treat analysis, incidence in the control group was so high, it was 9% per year, that has the lowest number needed to treat in terms of number of women who need to be offered the gel to be protected. You can see Adherence is somewhere in the middle, close to 4% incidence per year in the placebo group, so a little over 50 as the number needed to treat. So we heard earlier in the discussion strategy position, that's a huge amount of drug to be given people to prevent non-invasive infections. And again, we prioritize certain diseases over others because if you look at, as Lynn pointed out, statins, clinicians think nothing of prescribing statins to their patients to prevent a heart attack or cerebrovascular event. And that's up for 250 individuals having to take statins to prevent one clinical event. So this again is an important part of this course that we're thinking about. I think it didn't come out very well. I actually had some data from Fenway Health. So kind of curious do that because I had a graph. In 2011, we had 2 individuals outside the clinical trial who we infer had used PrEP. We had electronic health records, so we look at people who are HIV uninfected who had prescriptions for Tenofovir-Based for more than a month. For a month, we assume it might be post-exposure prophylaxis, but for more than a month, more likely to be PrEP. By 2013, it was up to 90 individuals, and it's well over 100 individuals already this year. So we definitely see that inflection point of individuals becoming more interested. And you can see that initially more racial disparities. You can see more about the age distribution as well. And Rosemary, Massachusetts, fairly liberal social democracy. We have very individuals who there have been insurance paid for their PrEP. So the other important thing is to contextualize this. I think many times people they say treatment prevention versus PrEP, and I think we have the tools now. Part of this is status awareness, and part of this is thinking about dealing with the concomitant social issues that may potentiate risk and lead to less adherence. But I think we get it all right. PrEP is a certainly important tool that we now have at our disposal. So I want to thank my colleagues both at Fenway and Adherence and other colleagues who visit us in the area. Thank you.